presentation, but I guess we can start just a brief introduction about so today we're actually presenting one of the best abstracts in ICML this year, so thank you to the Saudi Lymphoma group for the invitation. So one of the most interesting presentations is looking at the role of radiation therapy in primary mediastinal B-cell lymphoma. And honestly, if you look at the majority of the patients who come are usually young patients. They're usually in their 30s in a disease subset that's actually very difficult sometimes to characterize between a subset of a DLBCL or a classical Hodgkin lymphoma. So in this study, so if the IT can give me a hint that the presentation is in. So basically, this study was actually designed to see if a consolidation can actually add to the overall survival in those patients when they achieve a PET negativity at end of study. So ultimately, looking at all landscape of patients who come with the primary mediastinal B-cell lymphoma, you can see that a significant overall response rate can be achieved. A majority of patients can actually go into a complete remission, but ultimately, those who fail to achieve a good response at the beginning, they're very hard to salvage. That's why it's very important to keep so that's the study that I'm actually presenting today. So it's an observational radiotherapy as consolidative therapy post-standard chemoimmunotherapy. So it's a distinctive subtype of lymphomas. They're usually characterized by, they're all CD20 positive. CD30 positivity is a distinctive feature in there, and they're CD15 negative, which makes, Hodgkin a less likely diagnosis with a significant expression of PDL1, which is an interesting feature. Mostly, in 95, 98% primarily mediastinal disease alone, but a subset of patients, especially in our population, can be seen with a bone marrow involvement and below the diaphragm lymphadenopathy. The outcome of those patients is always excellent. However, if you look at the response to salvage therapy, these curves show that the survival probability is less than actually 30%, which makes it a very difficult disease to salvage. So why this is an important question at this point? We've got actually conflicting data. So if you actually see a lot of retrospective data, they actually show that consolidation therapy can improve overall survival in patients. So the SEER registry have looked at a good number of patients between 2006 and 11, and they said combined modality can improve survival versus just a chemoimmunotherapy alone. But if you actually look at the NCI trial, which was actually a landmark trial, a phase 2 that looked at just the EPOCH-R, you can see that they only used chemotherapy and their median overall survival has been very impressive. You're talking about 97, 98% in a population that has been followed for 5 years. So now, do we go with radiation? Do we actually just omit radiation? That's actually the whole goal of this study. So again, in those who achieved CR and their PET scan after 5 to 6 weeks remained negative, would you do a consolidative radiation or not? That's the question. The primary endpoint is PFS at 30 months, and I think that's actually a reasonable output or an endpoint in a study. If you're looking at a disease that if it doesn't relapse usually within the first 2 to 3 years, then the chance of relapse is actually becomes very, very, very low. The secondary endpoint is overall survival at 5 years, as well as the long-term toxicity from radiation as the intervention of choice. So the patients got actually a registration and a PET scan at baseline, as with all standard of care practices. They get a standard chemoimmunotherapy, and the most commonly used one is usually the common European protocol. So they used quite a bit of R-CHOP 21 in the induction setting. Some small population they get an R-CHOP 14. R-CHOEP is an option, and about 20% only they get the dose-adjusted EPOCH-R. So the continued therapy, once they achieve the final PET scan, then they will be stratified based on PET. So PET negative group, they will also be randomized in a 1-to-1 fashion to a 30-degree radiation to the mediastinal bulky area versus observation. So we're not talking about patients who are PET positive at end of therapy. So why do we choose a DIVEL score 1 to 3 versus above 3? So this is an interesting part that was actually presented a long time ago. Based on the CMR definition, the realized that 1 to 3 they do actually very well, and more than 3. So this was actually the rationale for the stratification based on DeVille score. Initially, the hypothesis was if you actually enroll 376 patients, you can actually get a significant one-sided power more than 80%. So the PFS that was actually in mind is 85% in both arms at about 3 months of randomization. They also had another hypothesis going on, which is the PFS, if it's less than 70% in the observation, then they achieve a non-inferiority margin, but that's something they didn't actually do in this study. So the aim for a 540 needed to be enrolled with an expected PET negativity of about 70%. In the interim analysis, which is, probably this is a case study in designing clinical trials, is they did 2 planned analyses and 1 unplanned, and they actually realized that the number of events that they captured was actually very low. So they had to redo the sample size calculation, which didn't weaken the study, in my opinion. I think they achieved a significant strength at the end of the study. But they realized based on the captured events, they needed 3,600 patients, which is almost an impossible number to achieve. So the IDAC committee came back again, and this is after 2021, and they said, listen, we need to continue the same study. We do not have to increase number of patients. And based on when we actually complete the accrual rate, at that time we'll redo a post hoc sample size analysis, and that's exactly what they did. So the follow-up duration is actually quite good. So those patients were actually followed for 5 years in both arm, observation and on the radiotherapy arm. So 545 enrolled in the study, 530 were actually accessible, 530 PET scan were reviewed, and then we end up with the 130 in each arm, which is, in my opinion, a very reasonable number. And then even if you do the post hoc sample analysis, you can see that they maintain more than 80% power. So the demographics of this study, so 130 in each arm, you can actually see that, as we would imagine, 65% in each arm are female. The performance status is excellent in all the patients. The median age is as what you would expect in the literature, people in their 40s and 30s. Bulky disease in more than 50%. Almost all of them, they had an elevated LDH. And the low risk to intermediate risk based on IPI scores. So the regimens, which is an interesting option here. If you actually see RCHOP 21 was given at about 20%. RCHOP 14 was also given in a 20 to 25%. And dose-adjusted EPOCH-R, which is the most commonly used North American protocol, is only given in about 15 to 20%. But if you actually remember from Lugano 2021, they actually looked at the outcome of patients who were given RCHOP versus other options, and unfortunately, those who achieved RCHOP, those who received RCHOP didn't do as well. So, end of therapy PET scan, almost all the study population had a good response, with development ranging between 1 to 3. But it's actually interesting to see that those who achieve DeVille 1, I don't know if this is a bias from our nuclear radiologist here or this is a function of the disease, but they barely give a DeVille score of 1. So only 5% in the study, and the majority, you're talking about 90%, had a DeVille score of 2 to 3. So the progression-free survival is almost overlapping. So the 30 months PFS, so the 30 months PFS was 97% in both arms. I'm not sure if beyond 72 months, the curves will overlap or not, but I think this is a reasonable follow-up duration. So the overall survival, you cannot see two lines, just the one line. 99% were alive at 72 months between radiation and radiotherapy and observation. So the PFS, you've got about 50% reduction, but that's actually not a significant statistical finding. So I think the conclusion from the study was, both curves are overlapping. There is no difference. So they went back and they did a statistical power, and they actually noticed that, at the detection rate with the PFS they actually captured, they still maintain an 86.1% power. So that makes this actually a very good study. So side effects from radiation, and other therapies, nothing really, pans out. 6 patients had side effects. Most of these things are unrelated to therapy. So in conclusion, the ILSG-37 study was actually the largest so far that looked at radiation versus observation. Mediastinal RT can be omitted in those who achieved a complete metabolic response at end of therapy, and in keeping with the bulk of the literature, if those who are PET negative, they can actually omit PET scan. They can actually omit the radiotherapy at the beginning, and that's pretty much it. Thank you very much.